Good afternoon for those in the US. Good evening for those in Europe, and good morning for those in California or in Asia. Um, I would like to introduce a very exciting webinar. A year ago, we only cared about the acute phase of COVID. And now we're still dealing with acute COVID, but we're also dealing with a wave of problems that came after the pandemic. And so it's about patients who recovered. Professor Ohana will first tell us about pulmonary complications. Then Dr. Kato from our here at Johns Hopkins will tell you about cardiac MRI assessment. And finally, Dr. Leopoldo Perez de Isla from Clínica San Carlos will discuss echocardiography assessment of these complications of COVID. And as the last presentation, Dr. Laurent Feldman from Hôpital Bichat in Paris is going to discuss strategies to use lower dose in interventional procedures. But I would like to start by asking Professor Ohana to tell us all about what happens to the lungs as people convalesce and survive COVID. Professor Ohana.
Thank you so much, Professor Lima, for the kind introduction. It's really my pleasure to be virtually with you here today or tonight or in the evening, depending on where you are from. And we will talk during the 10 minutes that I will have the pleasure to spend with you of the follow-up of lung parenchyma after acute COVID-19 and the potential role of chest CT. The usual disclaimer, these are my views, not those from Canon. And as an introduction, we can definitely say that COVID-19 is the first pandemic in the modern imaging era because this is the first pandemic when chest CT was right at the beginning. You see this publication from January 2020. It was right at the beginning, the imaging modality of choice for COVID-19, for acute COVID-19. For the positive and differential diagnosis, for risk stratifications, for follow-up of acute complications, PE, superinfection, ARDS, and maybe also, and that will be the topic of tonight, maybe also for long-term fibrosis. We have thousands and thousands of articles about chest CT in the acute phases, and all these articles demonstrate that chest CT is extremely useful. However, the role of chest CT in the long-term follow-up is still debated. Is there a need for that? Should we do it? Well, this is still an ongoing question in the literature. The real question is, should we screen patients for long-term lung parenchyma fibrosis? And as a tentative answer, I would like to share with you first our experience in Strasbourg. We are here in the northeastern France, and we were really in March 2020 inside the eye of the cyclone. We were in one of the most intense clusters in France, and our institution was basically a COVID-19 hospital for at least 3 months. And together with the pulmonologist, we prospectively followed patients that were hospitalized for COVID-19. And we published this in March 21. And we had a cohort of 81 hospitalized patients with COVID-19. And most of them, 45, had critical disease, which means that they went through ICU. All these patients had a comprehensive respiratory follow-up at 3 and 6 months with PFT, 6-minute walking test distance, a consultation with a pulmonologist, and a dedicated chest CT. And what have we learned from this cohort of 81 patients? Well, I think there are two sides of the study that I would like to show you. First is the clinical and the physiology follow-up. And what is important is that no oxygen therapy was required among the 81 patients after the initial COVID-19 episode. At 3 months, symptoms were seen only in 20% of patients. The 6-minute walking test distance was the same between groups, either in mild, moderate, critical, or severe disease. And DLCO was mildly impaired, but only in patients with critical disease. And what about the patient? What about the chest CT results? Well, more than 2/3 of patients had abnormal chest CT at 3 months, but only 50% had persistent abnormalities at 6 months. These persistent abnormalities on chest CT at 6 months were seen only in patients with initially critical disease, and they were rated as minor. So it looks like from this cohort that there is what we can call a disconnection between what is the physiology and the clinical evolution, which looks like relatively and surprisingly good, and the imaging where we still have some persistent abnormality after 6 months. So let me show you one caricatural example. This is a 51-year-old man that spent 3 weeks in medicine for acute COVID-19. This is the initial chest CT. This is a typical COVID-19, like everyone has seen like thousands of that. 1 week after, we have an evolution toward more alveolar consolidations. 1 month after, we have some persistent ground glass opacities, mostly peripheral, with some interstitial septal thickening. 3 months after that, the ground glass opacities are almost gone. We still have some very low density residual GGO, but we have also some subpleural septal thickening. And if we look at the 6 months follow-up, then it's almost back to normal, apart from some very limited residual subpleural reticulations associated with very mild bronchiectasis here and here. So this is like caricatural example because over the course of the COVID-19, well, usually you have initially ground glass opacities, then around like 10 days, it tends to be more alveolar consolidation. Then at 1 month, it goes back to a phase of ground glass opacities. And then you have some residual abnormalities at 3 months, and usually not very much residual lesion at 6 months. Okay, this is our experience from Strasbourg, but what about the literature? So on the literature, there are not that much publications. I found this publication, which is a meta-analysis of 15 studies with about more than 1,000 patients with follow-up chest CT. However, the average follow-up was only 3 months. And what the authors have shown is that more than half of the patient had abnormal chest CT at 3 months, and 44% had abnormal pulmonary functional tests. So it looks like here again, we have this kind of disconnection between the images and the physiology. This is a more interesting study. It's from radiology from January 2021. It's 140 patients from China, all with severe disease, but only 4 with invasive mechanical ventilation. And they had PFT and chest CT at 6 months. And while the author found that 35% had persistent fibrotic lesions at 6 months, yet only 14% had slight persistent dyspnea. So here again, we have this disconnection between imaging and symptoms. And finally, this is the study with the longest follow-up I've been able to find. It's only on 41 patients and only 2 patients with critical disease, but they've done a PFT and chest CT at 7 months. They found that 71% had complete CT resolution of the lesions, and 29% had fibrotic lesion. They do not say more details about the PFT results, but you can see what is considered fibrotic lesions is really, really mild, usually subpleural, very limited. So to try to give a conclusion, what can we say? What can we say 18 months after the outbreak of COVID-19? Well, for sure, it's considered usual to find persistent abnormalities at 3 months after the initial episode. Most of these abnormalities at 3 months will resolve if you do a long-term follow-up, and long-term is considered at least 6 months. And in patients that have residual lesion at 6 months, this will usually not resolve. And these residual lesions at 6 months and more are usually encountered in critical patients, mostly patients that went through ICU. These lesions are mostly peripheral, parenchymal bands, bronchiectasis, honeycombing, and they are mostly limited in their extension, and very rarely they go over 10% of the total lung parenchyma. Also in these patients, symptoms are usually quite rare. And so the question that remains and that is still unknown is the clinical significance of persistent CT fibrotic change that we could encounter at 6 months, while the patients are asymptomatic or very mildly symptomatic. So what should we do about that? I do not know, and I do not think that there is an answer in the literature currently. So what should we recommend to keep it simple? I think that follow-up chest CT, we should not do it before 6 months after discharge. Otherwise, it's too early and you will find lesions that you will not know what to do with. I think we should not propose follow-up chest CT to everyone, but only when you have either persistent symptoms, of course, or when the initial disease was rated as severe and or critical. This is where you have most of the lesions. Follow-up CTPA is not currently recommended. And to finish, I would like to highlight a very important point, the radiation dose. It should be adequately optimized in this patient. And as we've seen in this analysis from 28 countries published in radiology, it varies very, very, very widely. And you see that the DLP for follow-up chest CT was 341 milligray per centimeter, which is extremely huge. We can and we should do way better. To conclude, I would like to highlight the usage of the impact of DLR, deep learning reconstruction. This is the ACE technology from Canon. In 2020, we did a little over 1,000 examinations with the usual iterative reconstruction technique, and the mean DLP was 180 milligray per centimeter. You see that is already way below what is reported in radiology. And we did also the same year about 1,000 examination with the exact same acquisition parameters, but with DLR, with ACE. And you see that we managed to achieve a 24% reduction in radiation dose without doing nothing more. So it is very, very efficient, and this type of technology. And I believe that this is something that should be proposed when you have the chance to have it. So with that, I would like to thank you for your attention and pass on to the next speaker. Thank you very much.
Thank you very much, Professor Hanna. This was a great review. I would like to move to the second presentation, which is now focusing on the heart. We were also in the center of the first wave of COVID here at Hopkins, and to discuss cardiac MRI consequences of COVID, Dr. Kato, who is a senior scholar here at Johns Hopkins Hospital, will and is leading our investigation of convalescent patients, will discuss these alterations. Please, Dr. Kato.
Thank you so much, Dr. Lima, for your kind introduction. My name is Yoko Kato from Johns Hopkins University. The title of my presentation is a Comprehensive Imaging Exam of Convalescent COVID-19 Patients. This is my COI and disclaimer. Background. SARS coronavirus 2 infection affects multiple organ systems. Although pulmonary findings are the most prevalent presentation, COVID-19 may have multiple extrapulmonary manifestations. A comprehensive imaging exam of convalescent COVID-19 patients on MRI without ionizing radiation may be helpful for the risk stratification and adequate follow-up of post-COVID patients. In our facility, we have developed a comprehensive COVID MRI protocol which includes brain, lung, heart, and liver. In this presentation, I would like to explain our COVID MRI protocol, and after that, I would talk about our initial experience on our COVID MRI study. This is the COVID MRI protocol developed in our facility. It is a 1-hour scanning protocol, which consists from non-contrast imaging and post-contrast imaging. We first scan the brain and then move on to the liver and heart non-contrast images. And after that, we acquire the lung perfusion image under administration of gadolinium contrast. And after administrating the remaining dose of the contrast, we acquire the post-contrast lung UTE as well as cardiac MRI images. This is the detail of our brain MRI images. They are all non-contrast images. We acquire diffusion image and flow-sensitive black blood images for the vasculature assessment, MPRH for the brain volume and structure assessment, and T1, T2, and T1 raw mapping for the tissue characterization. And this is the liver MRI protocol. They are also the non-contrast images. We start from Dixon fat fraction quantification imaging for the fat evaluation. And then we acquire T1, T2, and T1 raw mapping for the tissue characterization. And then we acquire the lung images under contrast administration. This is the perfusion image for the assessment of pulmonary thromboembolism. And also we acquire the lung UTE for the assessment of lung fibrosis and other abnormalities. And this is the cardiac MRI protocol, which consists from non-contrast images as well as post-contrast images. And in the pre-contrast image, we acquire T1, T2, and T1 raw mapping for the tissue characterization, as well as cine image for the heart structure and functional assessment. And in the post-contrast image, we acquire LGE for the scar assessment, and also the post-contrast T1 mapping for the calculation of ECV values. From now, I would like to talk about our initial experience of the convalescent COVID-19 patient study at Johns Hopkins. The aim of this study is to characterize cardiopulmonary consequences of COVID-19 using state-of-the-art CT and MRI in individuals who needed hospitalization. The inclusion criteria is the participants who previously hospitalized for COVID-19 illness at the Johns Hopkins Hospital in the last 3 to 6 months. Those participants underwent both an ultra-high resolution CT and MRI images within 3 weeks of each other. And so far, we have scanned 11 participants, 4 male and 7 female. Their hospital stay period was 5.3 days in average. They received no ventilator or ECMO during the hospitalization. There was no history of cardiac disease, and 2 participants had a history of asthma. And 3 participants presented post-COVID symptoms such as palpitation or dyspnea on exertion. All these participants were with preserved LV ejection fraction over 50%. And this is a summary table of the lung and cardiac findings of 11 convalesced COVID-19 patients. The yellow highlighted cells presents the abnormal findings. There were 3 participants who presented post-COVID symptoms such as dyspnea on exertion and palpitations. On the chest CT analysis, there were 7 participants who presented abnormality on chest CT, which all of them presented ground glass opacity. And also in one patient, this case CC007, presented subpleural band-like opacity. And it is noted that these 7 participants didn't have necessarily have the symptoms, post-COVID symptoms. And this is a result of lung UTE findings. And out of the 7 chest CT abnormal findings, there were 3 participants who presented abnormality on lung UTE, which findings were corresponding to the chest CT findings. Also, there was 1 participant who presented subpleural linear opacity on lung UTE. And this participant is waiting for the chest CT so that we could confirm these findings on ultra high resolution CT. And this is the result of myocardial LGE. And there were 2 participants who presented LGE, which LGE distribution pattern was non-ischemic pattern. It is noted that both of the LGE positive participants presented abnormality on chest CT findings or on the lung UTE. From the next page, I would like to introduce some of the representative images. The first case will be this CC003 who presented multifocal GGO on chest CT, as well as corresponding findings on lung UTE. The second case is this CC007 who presented chest CT abnormality as well as lung UTE band-like opacity. And this participant also presented myocardial LGE. So this is the first case. It was a 58-year-old male who presented multifocal GGO on chest CT. And in the corresponding slice of UTE, we can recognize the high intensity area, which is looks like the same pattern as on CT. And this is the second case, who was a 63-year-old male who presented lung abnormality as well as myocardial scar. So on chest CT as well as on lung UTE, we could recognize the band-like opacity in the left lung. And on the myocardial assessment, we could recognize the LGE scar in the mid wall of the inferior septum. And we could recognize also the corresponding ECV ECV value in the inferior septum. Discussion. The high prevalence of lung abnormalities such as GGO and band-like opacities on CT are reported in post-COVID patients. The high prevalence of lung abnormalities in our initial observation was in line with the publication. Our study presented myocardial LGE scar in 18%. In a study on post-COVID patients, cardiac involvement is reported in 78% of cohort, in which LGE scar was observed in 32%. These pulmonary and cardiac abnormalities in our study were observed even in participants without post-COVID symptoms. And this is a conclusion. A comprehensive multi-organ MRI assessment may benefit the convalesced COVID-19 patients by detecting the subclinical findings, which may need careful follow-up. Thank you for your attention.
Thank you very much, Dr. Kato. Fantastic presentation. And I myself have a lot of questions, but I'm going to save them to the end. And I'm going to ask Dr. Leopoldo Pérez de Isla, professor at Universidade de Madrid in Clínica San Carlos, to talk to us about echocardiography, which was the most versatile tool during the acute phase and is going to be very helpful in the convalescent period. Dr. Pérez.
Thank you very much, Dr. Lima. It is my pleasure to join you today. Let me show you the title of this presentation. The title is "What is the role of echo after recovery from COVID-19?" But I would like to change a little bit this title, and I would like to see you this new title, How My Canon System Might Help Me After Recovery from COVID-19. And this is the real thing. First of all, I would like to tell you that the things that I'm going to show you, the cases I'm going to show you, the clinical scenarios that I'm going to show to you are not based on scientific evidence, but they are based on scientific experience. I mean, these cases and these conditions and these clinical scenarios are taken from real life because we had the need to deal with a lot of patients, with COVID patients, during the last months. And we have learned that our Canon system, our echocardiographic system, it is very useful for two things. The first thing is to rule out, and the second thing is for the early detection. And let me explain you these two concepts. Rule out what? Rule out the presence of heart failure, the presence or the causes of chest pain, the presence of coronary endothelial dysfunction, the presence of pericardial involvement, and the presence of dysautonomia or inappropriate tachycardia. And after that, we will talk about the early detection of several problems. But starting with the rule out, we have to rule out the presence of myocardial dysfunction. In the previous presentation, we have seen that it is very frequent to find in these patients myocardial scars and myocardial dysfunction. And we know that COVID-19 is able to produce myocardial dysfunction by itself, but it is also able to decompensate a previous chronic heart failure. So we have these two problems, and sometimes it is very useful to differentiate between heart failure and another problem, such as the COVID-19 lung involvement, because it has very important clinical implications. For instance, if we have a patient with an acute respiratory distress syndrome secondary to COVID infection, and this patient suffers volume overload because of, for instance, heart failure, we are mixing two very important, two crucial conditions. We are putting in the same patients two very important conditions that can lead to a life-threatening situation for these patients. So we need to make for sure that the heart is pumping well or not pumping well, or there's any problem in the heart. And we do it by means of echocardiography, such as this case that I'm showing to you in this video. And my Canon system is able not only to show me this left ventricle, my Canon system provides me with more information because we can use some systems such as the auto ejection fraction, the auto EF. And with this auto EF, we can obtain the left ventricular ejection fraction in a very, very easy and a very fast way. The second rule out, chest pain and coronary endothelial dysfunction. We have learned that some patients can suffer from angina with normal epicardial coronary arteries. So in these patients, what is happening is that the COVID-19 has provoked a coronary endothelial dysfunction. And in these cases, can be very useful, for instance, that with an echocardiogram, with an stress echocardiogram, we have to rule out the presence of coronary epicardial stenosis. So in these cases, my echocardiography system is also able to provide me with information that is crucial for the management of my patient. The third one, pericardial involvement. We have seen some patients with pericardial involvement, above all with pericardial effusion. It is not very common to find cardiac tamponade, but in some cases we have seen cardiac tamponade in these COVID-19 patients. So my ecosystem is able to tell me what is happening, and not only what is happening at the level of the pericardium, but what is happening at the level of the cardiac chambers. There is tamponade, or there is no tamponade at this moment with this patient. And finally, the last rule out, the presence of dysautonomia or inappropriate tachycardia. To confirm this diagnosis, we need to be sure that structurally my heart is completely normal, and echocardiogram is one of the basements for this diagnosis, the diagnosis of normal, structurally normal heart. So this is the fourth rule out. And now we are going to change from rule out to early detection, because my ecosystem is also able to detect in a very early way some problems, starting with the myocardial dysfunction. So we have seen during the last decades that with echocardiography, we can detect early myocardial damage. This is one of hundreds of studies demonstrating that in different scenarios, in different clinical scenarios, in different conditions, in different diseases, we can evaluate the myocardial function and we can detect the myocardial dysfunctions even earlier than when we use the left ventricular ejection fraction. This is a very nice study that we published, and I love this study, and we published it in 2011, so a lot of years ago, but it is during this pandemic, these findings are still valid, are still useful, because we know that left ventricular ejection fraction is not exactly the same as left ventricular contractility, because contractility is the inherent property of the muscle of the myocardium to contract, not depending on the loading conditions. So it is the intrinsic property of the myocardium to contract. This is contractility. But left ventricular ejection fraction depends not only on contractility, but it also depends on preload, on afterload, and even in heart rate. But with echocardiography, we can study the contractility. It's not exactly contractility, but we can go a step ahead from left ventricular ejection fraction. And we can do it by using another systems, such as the auto ejection fraction, as we have shown in a previous slide, but we have even more accurate systems, such as this wall motion tracking. Our Canon system provides us with 2D wall motion tracking and 3D wall motion tracking. Wall motion tracking is the name of Canon of the speckle tracking. This is the generic name, and wall motion tracking is a specific name when we work with a Canon system. And this system is very accurate, and this system can detect in a very early way myocardial damage. This is an example, and this is an example in which we can study this left ventricular, and in this case from a 4-chamber view, and in this case it is completely normal. We can say, okay, I'm expert in echocardiography, I don't need this wall motion tracking. Okay, I can agree with you, but I think that you can agree with me if I say to you that not anyone is not everyone is an expert in echocardiography. We have residents, we have fellows, we have even non-cardiologists doing echocardiograms, and they can feel very happy, very glad if there is an automatic system and a very easy to use system that provides them with information based on a very accurate technology regarding the contractility of the heart, the contractility of the myocardium. The second, early detection, pulmonary embolism. Sometimes from the clinical point of view, pulmonary embolisms can be a little bit hidden, but when we use the echocardiogram, we can detect some problems such as this large right ventricle that give us a clue that must lead us to detect the pulmonary embolism. So in these cases, echocardiography is also very useful. And when we talk about well motion tracking, we are not talking only about the analysis of the left ventricle, but we are talking about the analysis with this technology. In this case is the 3D well motion tracking. With this technology, we can analyze the right atrium, the left atrium, the right ventricle, and the left ventricle. So we can complete a very global and a complete analysis of the 4 chambers of the heart. And third, infective endocarditis. Sometimes, above all, in those patients that have been admitted to hospital and that have been admitted to the coronary care units or intensive care units for a long term, for a long period, for a long number of days, usually they suffer from infections and we have to rule out endocarditis. In these cases, my Canon system is also able to help me because we can use the transesophageal probe in order to detect the presence of vegetations in the valves. We can use not only the 2D image, but also the color Doppler images, and we can also use the 3D images, and you can see how the accuracy of these images is really nice. And we can use it in order to detect vegetations, combining the 2D and the 3D transesophageal images. And we can also analyze, and we can also do a cast of the valve in order to analyze the valve, in this case, the mitral valve, and we can obtain a lot of different measurements based on the tracking of the leaflets of the mitral valve in these cases. You can see how this case was very difficult for the system because this case was a patient that was suffering an atrial flutter and his heart rate was very high. And even with this difficulty, the system was able to track the valve, to track the leaflets, and to provide me with a cast of the valve that it is easier to analyze that the valve, the echocardiographic image of the valve itself. And for sure, we can also use the 3D color Doppler to analyze any regurgitation, any mitral regurgitation, for instance, this one, that it is mild mitral regurgitation, but my system is able to detect it in 3D mode. And finally, the presence of thrombus. My ecosystem is able to detect different thrombus at different locations. We have seen several important thrombosis, generalized thrombosis in COVID patients, and my echocardiogram, above all, especially my transesophageal echocardiogram, is able to detect all these thrombus. So to conclude my presentation, I would like to say that my Canon system, my EchoCanon system, is able to rule out several things that are very frequent in patients with after COVID-19, and it is able to detect in a very, very early way some problems that are not seen using conventional techniques, using traditional systems, and using another kind of things. We are not as accurate as sometimes as CT or cardiac MRI, but we have an advantage by using echo, and it is the temporal resolutions and lot of different clinical scenarios, this temporal resolution is crucial for the management, for the diagnosis and the management of the patients. And this is my presentation. I hope you have enjoyed it. And I give the turn to Professor Lima to continue the meeting. Thank you very much.
Thank you so much, Professor Perez de Isla. Fascinating presentation. And again, we have a lot of questions to you. The fact that you have so much experience is so amazing, amazingly helpful. One of the constant messages here is dose. You saw Professor Ohana really highlight the issue of radiation dose. And what we are going to do next is to have a presentation by Dr. Laurent Feldman from Hôpital Bichat in Paris about lowering dose or using strategies of low dose during cardiovascular interventions.
So hello, everyone. My name is Laurent Feldman. I am a cardiologist in the Bichat Hospital in Paris. I am the head of the cath lab, the coronary cath lab. We have 2 rooms here. And it happened that in 2019, we got these 2 new Alpha Nix Core Plus rooms. And that's why I was asked by Canon to give you some insight about dose reduction solutions that were provided by these rooms and that we're using now on a routine basis. We have installed 2 cath labs, 2 Alpha Nix Core Plus rooms at the end of 2019. This is an overview of the design. You can see that it fits in very well in pretty small rooms of in the 50 square meter range. So let me just go through some of the tools that we're using routinely to reduce irradiation. The first one is called the dose tracking system, DTS. DTS is a very intuitive system which provides you a skin dose during your intervention. So there is a color coding from blue to red. And of course, when you are in the yellow to orange range, so you know that you're not on the safe side. You have to modify your projection. And this is a very fine way to measure, to monitor your irradiation. This is a second feature that we're using now by default. It is called the live zoom. Live zoom provides you a magnification of your views, but without increasing the dose. On the left, you have a normal irradiation. On the right, we're using the live zoom. So virtually, it provides you with a field of view of 17. You can even get smaller field of views. But without increasing the irradiation dose. You can see here that actually it reduced dose by 35 to 48%. So this is a very interesting tool to have a big image, good definition, but low dose. Spot ROI is another feature which is very unique to the Canon Alpha Nix Core Plus rooms. Basically, the idea is to provide you with a very good definition of an area of interest, in this case, the circumflex artery, but with an attenuation of what is around this area of interest. So this allows to reduce the dose by more than 60%. And so this is a feature that we're using, especially in very complex PCIs and OCT and CTO, when we know that we're going to spend a lot of time and that dose reduction is particularly important. Stent enhancer is another feature that we're using a lot. It doesn't reduce dose per se, but it gives you a very fine definition of the way your stent has been deployed. And by doing so, you don't have to do extra runs of angio, and so altogether you reduce the dose. There is an alternative to a stent enhancer, which is the one-shot function. It's only one frame, and if you do this properly, you can have a very fine definition of your stent. You can see here there is some under deployment of the stent, and this clearly reduces the dose. Another way to reduce the dose is to use less X-ray and to do multimodal imaging. We have integrated in our Alphenix Core Plus rooms different imaging and physiology systems. You can see here to the left the OCT from Abbott, FFR. It works very fine with Abbott or Volcano, whatever system you have. This is the IBIS of Boston Scientific, which has also been integrated in the system. So because it is integrated, it's very easy to use, usually with one switch, and we use this a lot. So more imaging, more physiology, and less X-ray. That's a fine way to reduce those. So this is it has been a very quick overview of the dose reduction system that we have in the Alphenix Core Plus rooms. Of course, you are more than welcome to come and visit us at Bichat Hospital in Paris to check all these functions live. You'll be welcome, and just let me know. Thank you very much for your attention.
And we thank Professor Feldman at a distance from this very nice presentation. We have a few questions, and we are going to start with Professor Hama, a question of fibrosis of the lung, which is something that we are all concerned about. Is there any treatment for that specifically? One of our viewers has asked.
So indeed, that's an excellent question. There are medical treatments for idiopathic fibrosis, such as nanditanib, for example, that are used in a patient with definitive idiopathic fibrosis. And the question is, could we use this type of treatment in COVID-19 patient? And back in last year, like in the very early phase of the pandemic, this was really a huge question. And people were trying, could we use it or not? And there have been some very limited experience with that. And I believe that based on what we have seen with the evolution on chastity and the relatively limited fibrotic lesions, that it will not be something widespread. Maybe it will not even be something proposed to COVID-19 patients. Currently, this is only research. I believe that there are like very few protocols that have included patients. I don't know if we will have definitive answers with that, but this is currently not something that we can use routinely.
Thank you. That's extremely helpful. Still on the theme of fibrosis, Dr. Kato, you showed a big scar. This has been reported with varying rates in post-COVID patients, but it's always there depending on how sick the patients were during hospitalization. Do you expect problems from scars such as the ones you showed?
Yes, so we don't know exactly what happens based on those scars. It needs to be investigated with careful follow-up. And also, so that we need multimodality imaging of the myocardium, such as including not only cardiac MRI, but also maybe we could use other echocardiography follow-up or other things. And so that, yes, and also using cardiac MRI is my favorite, and it is very good to follow up those scars with LGE as well as ECV, native T1, such as.
Thank you. One of our viewers, Professor Perez, has asked, is global dysfunction common, found at all? Is this something we should worry about after COVID-19 infection?
First of all, I agree with Dr. Yoko Kato. I prefer MRI; it's my favorite one. But sometimes I cannot take the MRI to the surgery or to the room of the patient. Okay, and I have to deal with my echocardiogram. No, okay, it is not frequent. It is not frequent to find a global dysfunction of the left ventricle or even the right ventricle, and I think that it is a little bit more frequent to find a right ventricular dysfunction secondary to the embolism, to the pulmonary embolism, but not frequent, not very frequent at all.
Another question I have for you, Professor Perez, is in those with tamponade, we are very interested at Hopkins. Do you find that they also had concomitant myocardial disease? Were troponins elevated, so on and so forth?
Yeah, usually if we find a pericardial tamponade or pericardial fluid, we usually find lesions at the level of the myocardium. Usually in these patients are studied also with MRI, and even in those patients with a normal, a normal echocardiogram of the left ventricle, when we study them with a cardiac MRI, we can find the scars such as the previous that we have seen previously in the presentation by Dr. Yoko Kato.
Thank you. I know that another question here was about the role of lung, ultrasound in the lung, pulmonary ultrasound in COVID, either acute or chronic. I can start with Professor Hanna, ask him, do you use at all ultrasound to study the lungs?
No, indeed, this is something that has been published quite extensively for the acute phases with limited results. But for example, in our institution, we do not do any lung echo for COVID-19 patients. In the acute phase, the lesions were relatively limited, and I believe that in the chronic phase, lesions will be very difficult to see on ultrasound. So I do not think that there is a place for ultrasound in the chronic phase, at least for the lung parenchyma evaluation, of course.
How about you, Professor Perez? Was ultrasound used routinely?
Okay, yes, but usually in the hospital, the cardiologist is not involved in the echocardiogram of the lungs. Usually is the doctor in the intensive care unit, the one involved in performing this kind of examinations, and they really use it. They obtain very useful information, but usually in the acute phase, not in the chronic phase, not in the after COVID status.
I see. To Dr. Kato, in terms of fibrosis of the heart, and I know you've been doing T1 mapping. We know there's that paper, at least from China, showing pretty clearly that fibrosis was increased in, at least in patients that had severe COVID. Have you found any alteration at all on T1 mapping?
Thank you so much, Dr. Lima. And from our initial observation, there were a few cases, actually 2 out of 11 cases, that was with elevated global ECV value as well as elevated native T1 value. And at least one of them had pulmonary embolism, and we are still observing some post-COVID those cardiac abnormality, not only on native T1 and ECV, but in some cardiac functional assessment. So that, native T1, ECV, such fibrosis assessment is effective.
Thank you. That's very interesting that you mentioned dysfunction, but I'm gonna turn to Professor Hanna. There's a question here. What is the rate of resolution of ground glass opacities or opacifications what is their natural history in COVID in your mind?
So usually what we have encountered for ground glass opacities in the very early acute phase, like less than 5 days after the onset of symptoms, usually it's mostly ground glass opacities, and it goes to alveolar consolidations with reticulation. And then after 2 or 3 weeks, then you have a resurgence of ground glass opacities that could last for about like a month or so. And then there is like ground glass opacities are disappearing again. So it looks like you have ground glass opacities in the very early acute phase and in the post-acute phase. And then you have only fibrotic lesions. Of course, this is not like for every patient, but this is like a usual
the general picture.
Yeah, scenario.
That's very interesting. I think we have time for one more question, and it relates to contractility, as Professor Perez mentioned, and I'm going to turn to Dr. Cato as well. What is your favorite technique to assess myocardial contractility? Professor Perez.
Dr. Cato, your turn.
Okay, thank you so much. So recently, my favorite is strain analysis because we can know the detail, so we can have more information compared to the traditional LV ejection fraction.
I completely agree with you. I wish I could do this examination to every patient based on MRI, but we are not able to do that. We cannot afford it. And sometimes echocardiography could be very useful for these patients. It's not as accurate. It depends very much on the quality of the acoustic window, but it is a method that you can use in a very wide number of patients, in a lot of patients. But I agree that contractility should be the basement for the assessment of the left ventricular function.
Well, thank you very much. I think this was an amazing group of presentations, and I learned a lot. And I would like to thank each one of you for this contribution. And we'll stop here. And even though I'm sure there'll be questions coming, but we are at the top of the hour, and I would like to thank you all for your amazing contributions to the seminar. Thank you.